The title of my talk is on the role of multigene assays in the management of early-stage breast cancer. So the outline here we'll start out with is just a bit of the topic of precision medicine. Obviously, this is in the news. We have initiatives both publicly and privately to advance precision medicine. We'll talk a little bit about how breast cancer really has led the field in this area, and then specifically as it relates to the importance of the estrogen receptor. Then we're going to go on to talk about multi-gene assays and the use of those both for prognosis as well as prediction of drug benefit. And then moving beyond these panels, what are the next steps? So the definition for precision medicine obviously varies, but I think most people would say the generalized consensus that this is application of omic type analysis and systems biology to analyze the cause of the patient's disease, but also to utilize targeted treatments to address this disease process. So I like to divide this into prognosis, that is the natural history of the disease, as well as predictive meaning will this biomarker help me decide whether or not the drug will work, either as it relates to toxicity or benefit. So as it relates to breast cancer and the estrogen receptor, we really do have a huge amount of data as it relates to the precision medicine and the estrogen receptor. This is data from the Oxford Overview, and as you know, tamoxifen has been shown to substantially reduce the risk of recurrence. And down below here, you can see that the relative risk reduction in terms of recurrence is nearly 40%. But we also know that the aromatase inhibitors on the right in these same postmenopausal women have resulted in additional gains over tamoxifen. And so we clearly do have a number of different drugs that are available to treat patients with breast cancer. And importantly, the estrogen receptor is predictive. So we know that from this next slide that the hormonal therapy does not work for estrogen receptor negative breast cancer. And here you can see that with regard to the outcomes of patients treated with tamoxifen versus control when the tumor was estrogen receptor negative. Well, a major question over the last 10 to 15 years, however, has been for these ER-positive patients, should we be treating them with chemotherapy? So we have data from the Oxford Overview that really does suggest that there is benefit for women with ER-positive breast cancer, whether they enrolled onto studies below the age of less than 55 or on the right here, 55 to 69. And you can see that there clearly is a benefit, but that benefit is modest. It's about 5 to 6%, as opposed to that absolute benefit of hormonal therapy that you're often talking about 12 to 15%. So I think in summary, 3 decades of work here, we focused on understanding the biology of ER-positive breast cancer. We're able now to accurately identify the ER. That's true precision medicine. And there's huge benefit of adjuvant hormonal therapy. And with regard to chemotherapy, I think you'd agree with me, there's just some modest benefit. So a major goal over the last 10 years is to identify molecular signatures that can select patients who could avoid systemic chemotherapy. So here's a common clinical scenario. We see this every day. 58-year-old female with mammographically detected breast cancer. She underwent a lumpectomy. Pathology demonstrated invasive ductal grade 2. You could fill in the number here, but anywhere from a 2.5 to 3.5 centimeter tumor. She's sentinel lymph node negative. Her tumor suggests that it should be hormonally responsive. Adjuvant online right now is not available. It will be up soon, but in the past, adjuvant might suggest that this woman has a 20 to 30% risk of recurrence. So we do have data from the NSABP, and this was a clinical trial, very important clinical trial, in which women with node-negative ER-positive breast cancer were randomized to either CMF followed by tamoxifen versus tamoxifen alone. And as you know, in this trial, there was actually a fairly significant benefit for both relapse-free survival and overall survival. And the question that came out of this trial was, of course, should all women with lymph node-negative ER-positive breast cancer then receive chemotherapy? If you look here on the right, you can see that the hazard ratio for death is about there's about a 28% reduction. So when these data came out, of course, I think many of us in the clinic would suggest that we didn't know who would benefit, and so we did treat many of these patients with chemotherapy. Well, this slide just goes on to, again, illustrate the fact that there is great heterogeneity, both as it relates to the biology of the primary tumor, its ability to metastasize, great heterogeneity, obviously, in terms of the individual host and whether or not tumor cells actually have the ability to develop metastases. Some of this heterogeneity has been solved a bit, if you will, with the advent of the breast cancer molecular subtypes. Many of you are familiar with the terminology of luminal A, luminal B, HER2, and basal-like. This terminology actually came out of a unsupervised clustering of genomic data, and it's been adopted into our practice. Oftentimes, even though we don't necessarily use this particular assay, people will talk about a luminal A versus a luminal B. But really, in order to use this terminology, technically, one would have to actually run this particular assay. But this clearly was a major step forward. And we now know, of course, that there are many different multi-gene assays that are out there. Here you can see that these range from the MammaPrint, the so-called 21-gene recurrence score, or Oncotype DX, BCI, PAM50, Genomic Grade Index, EndoPredict, Mammostrat. So many of these are actually available right now. And of course, a major question that comes up for practitioners is, how should I use these? When should I use them? When are they prognostic? When are they predictive? So MammaPrint was one of the first that came out. This was a signature that was, initially identified patients with either good or poor outcome with relatively good accuracy, first published in 2002 in Nature. And the utility of this was published in the New England Journal of Medicine, showing that using the St. Gallen criteria, which is a very commonly used criteria for determining either low or high-risk patients, you could see that when adapting the MammaPrint within both the low risk and the high risk right here, that the MammaPrint could actually substratify these patients. And so within a group of low-risk patients, you could identify patients that would actually have a higher risk. And conversely, in a group of patients that were considered very high risk by St. Gallen, as it turns out, that the signature could identify that there's actually a subgroup of patients that would be predicted to do well. So what about prospective validation? Well, this is actually this particular assay is being prospectively validated in a European trial called the MINDAC clinical trial. In this trial, clinical pathological and MammaPrint high, these are patients that have both clinical high risk and MammaPrint high risk. They all get chemotherapy. And patients that have both pathological and MammaPrint low-risk features get endocrine therapy. And when there's a discordance between these two different scenarios, that is the genomic and the clinical factors, there's actually a randomization to whether to use the clinical pathological factors or to use the 70-gene signature. We don't have data on this trial as of yet, but we hope to actually have that in the next couple years. I'm going to move on to the 21-gene recurrence score. Many of you are very familiar with this. And so we'll rapidly go through this. This particular score includes genes involved in proliferation, HER2, estrogen, as well as a number of other genes involved in invasion, and then 3 other markers here. And this particular recurrence score, or this particular multi-gene assay, is heavily weighted towards proliferation, as well as HER2 and the estrogen receptor. And as you know, this recurrence score has been validated in multiple different data sets. Here, this is the B14 clinical trial. Again, this is a group of women that received tamoxifen alone for node-negative breast cancer. And you can see that the recurrence score is prognostic. It identified patients either low, intermediate, or high risk. Well, this particular recurrence score has been prospectively validated. This is a clinical trial called the Taylor RX trial. And in this trial, patients, I'm going to move over here to the left-hand side, who are low risk by the 21-gene recurrence score receive hormonal therapy. Patients who are high risk receive chemotherapy plus hormonal therapy. And as you know, those patients that are so-called intermediate risk get randomized to either endocrine therapy alone or chemo followed by endocrine therapy. Now, I just mentioned that this trial recently reported out the low-risk group, and I'm just going to briefly go over these data. these data were quite compelling. What they demonstrated is those patients who had a recurrence score of 0 to 10, actually over 1,600 patients, the risk of distant recurrence was exceedingly low, in that 1% range. And I would point out here, if you look at freedom for recurrence at any site, interestingly, what we do here, there's a box within a box, and that's because you literally have to blow it up and go from 80 to 100 to see such a tiny risk here for recurrence. So overall, clearly, for this assay, this has been fully validated both in secondary analysis of prospective trials and now in a prospective trial. Well, this assay has also been looked at in node-positive patients. This is the SWOG 8814 clinical trial where patients with ER-positive, node-positive breast cancer received endocrine therapy alone, and that was tamoxifen, or chemotherapy with CAF followed by tamoxifen. And you can see here in this study that it was prognostic both for disease-free survival and overall survival. So what we now know, of course, is that this assay clearly is prognostic. But obviously a major question for us in the clinic is, can these multi-gene panels predict drug response? And, most of these panels are weighted towards proliferation. And thus, with these high-risk patients, the hypothesis is that patients with high-grade tumors or high-risk features with high proliferation genes may be actually the ones that generate the most benefit. So this is the NSABP20 trial, and as you recall, I showed you these data, the long-term outcome, which patients were randomized to hormonal therapy alone or hormonal therapy followed by chemo. And you can see this is a secondary analysis of this trial. There was just a subset of the tumor blocks that were available, published by Soon Paik and JCO back in 2006. What you can see here is that overall, again, we see this modest but small benefit of chemotherapy. But in the low recurrence score patients, there was absolutely no benefit of chemotherapy. In the intermediate risk group, there was really no benefit either, although this is clearly underpowered. And in the higher risk group, that is the high recurrence score patients, here you see quite a large benefit with regard to chemotherapy. So based on this, we began to see new recommendations that came out with the suggestion that patients with low recurrence score really should not be treated with chemotherapy, that is ER-positive, low recurrence score. Intermediate risk patients, really the data doesn't really look to me much like there's going to be much benefit, but this was underpowered, so there was a large clinical trial, the TAILOR-X, which was designed to answer this. And of course, high recurrence score, the recommendations by groups are that these patients receive chemotherapy. Well, what's driving the benefit here? And you can see this is a table 2. This is the likelihood ratio for the test of interaction. You can see as it relates to the recurrence score in the NSABP20 that actually what's driving most of the benefit is actually the proliferation gene group within the recurrence score. In other words, there really was no difference between the overall recurrence score and the proliferation group. What about another data sets? Well, again, in the SWOG 8814, a similar finding, that is in the low recurrence score patients, even though these patients are clinically high risk, they have positive lymph nodes, but they're biologically low risk. You can see that, if anything, patients who got the chemotherapy actually were doing perhaps a little bit worse. And then in those patients with the intermediate risk, we begin to see a little bit difference. And then, of course, the high risk, we begin to see the benefit, the clear benefit of chemotherapy. So this assay is also being prospectively validated in node-positive breast cancer. This is the RX-Ponder trial, and that's there for you to look at. So what do the NCCN guidelines say about this? Well, you see in red here, the 21 gene recurrence score can be considered in patients with, obviously, node negative. That's where it's recommended, but also in patients with 1 to 3 positive lymph nodes to guide the addition of combination chemotherapy. And then you also see down here, it's not highlighted, but there are other prognostic multigene assays that I just showed you may be considered to help assess the risk of recurrence, but these have not been validated per se to predict response to chemotherapy. Okay, so ASCO actually just recently came out with guidelines, and these really mirror the NCCN guidelines. But here for Oncotype DX, or the recurrence score, you can see what it says. If a patient has ER-positive, HER2-negative, no-negative breast cancer, the 21 gene recurrence score can be used to guide decisions. You can see the type of evidence; it's quite high. And also, if patients who have ER positive, HER2 negative, or node positive, the ASCO guidelines are, a little bit more conservative. They say the clinician should not use the 21 gene recurrence score, and I think that obviously there's a little bit of debate on there. This is a conservative, if you will, assessment, and I think it's probably reasonable. But as the NCCN said, I think in patients with node positive 1 to 3, it could be used along with other factors to make a determination for chemotherapy. One of the questions I get asked a lot is, should we be ordering Oncotype on HER2 positive? And the answer is absolutely not. You should not be ordering Oncotype on HER2 positive breast cancer or in triple negative breast cancer. Okay, so we're going to move on to the EndoPredict. This is another assay that's out there. This has really been used in Europe. It's been out for a while. This is an 8-gene recurrence score. And the EndoPredict uses both the clinical assay, that is the EP clinical score, which combines nodal status and tumor size, along with a molecular assay. This is called EP Clin. So you have EP, which is the biological part, then the Clin, which combines the clinical part. And you can see here that this is actually a validation in the ATAC. This was just recently presented at the San Antonio Breast Cancer Symposium. And you can see both EP alone and EP Clin, that it was very prognostic in terms of identifying low versus high-risk patients. Now, I'm going to go on and just show you briefly. This actually compares directly head-to-head EP Clin as well as the recurrence score. And you can see that in node-negative breast cancer patients, there was perhaps a modest or a bit of addition for EP over in terms of a likelihood ratio, in terms of its ability to add to the recurrence score. But if you look at the next slide, and you can see how in the node-positive patients, there seemed to be greater addition or greater information that was added by EP Clin over the recurrence score alone. And that's just kind of shown here. You can see up here in terms of EP alone versus EP Clin in patients with node-positive breast cancer. There really is this assay really can stratify quite dramatically a group of patients that appear to be very clinically and biologically low risk, that obviously with this type of risk of recurrence could probably avoid chemotherapy. So the ASCO biomarker does talk about EndoPredict. It may be used to guide decisions on adjuvant systemic chemotherapy. Should not be used for HER2 positive or triple negative breast cancer. Going on, the BCI, this is a biomarker consisting of 2 independently developed biomarkers. What are these biomarkers? There's the HOXB13 IL-17 gene ratio that was first published in 2000. I believe it was 2004. My group actually validated this in another study in 2006. And then there's another part of this called the molecular grade index, which is a 5-cell cycle-related genes, really focusing on proliferation. And here we see the initial publication with regard to HOXB13 IL-17. And then here's the molecular grade index, which can really identify, for example, its value is identifying patients who are grade 2 in terms of discriminating whether they're either biologically high or low risk. These are additive. We're going to go on, and I'm just going to skip through this for the purposes of time and go right to the data with regard to ATAC. So in ATAC, this assay BCI was looked at. It did distinguish 3 risk groups in patients or in years 0 through 10. You can see that right here, and this was highly statistically significant. Notice that, however, that with the BCI, there's this additional advantage that it can identify late recurrence risk groups. This is in years 5 through 10. Again, this is statistically significant, and essentially you have either low risk groups or intermediate and high risk groups, which appear to be doing about the same in terms of their risk for recurrence. The second group, which comprised about 40% of patients in ATAC, had about a 13% risk versus the first group, which was about a 3.5% risk. This assay was looked at in the MA17 trial, which, as you know, randomized patients to either letrozole or placebo after they received tamoxifen. These tumor blocks at the time of initial diagnosis, that is before the patient even started on tamoxifen, were used. RNA was collected, the assay was run, and essentially what the assay showed was that it appeared that the greatest benefit of letrozole appeared to be in those patients that were high risk. In fact, there was about a 65% relative risk reduction in terms of the benefit of letrozole, but in patients who had the low-risk group, there appeared not to be as much benefit. So what does the ASCO biomarker guidelines say about BCI? It says that you can use it to help guide decisions on adjuvant systemic therapy. I would point out, this many people don't know this, but this assay really has shown value in node negative. So there really has not been much value with this assay in terms of node positive, and I think that's still being worked out, and that the ASCO guidelines do point that out. So again, should not use this assay for HER2 positive or triple negative. Many of you know U.S. Medicare allows for the use of this test to predict the risk of late recurrence, and so that is currently covered. Okay, the last I'm going to spend just a few minutes on is the so-called PAM50. Again, knowing here the intrinsic subtypes, these first molecular subtypes identified by Chuck Peru et al. This is just an update of that in a recent Nature Medicine paper a few years ago. And the intrinsic subtypes, at least for ER-positive breast cancer, a signature actually has been developed, and that's called the PAM50 ROR, or risk of recurrence. This has been validated in multiple different studies. This is just one particular study here, the ABCSG8, and you can see here that the PAM50 ROR can identify patients at low, intermediate, or high risk of recurrence. What about late distant relapse-free survival? So this is in patients in years 5 through 10. And you can see that there may be some benefit with this assay in identifying patients with a late risk of recurrence. But I think we need a little bit more data about that than in other studies as well. So again, what does the ASCO biomarker guidelines say? They say if a patient has, or if you may use this PAM50 ROR score in conjunction with other clinical pathological variables to guide decision making. They point out that for node positive, you probably should not use it. And of course, if they have a triple negative breast cancer or HER2 positive, the data are insufficient. Okay, so a summary. I'm going to just finish there. There's many of these multi-gene panels that are now available, and I think obviously the one that has gained the most traction in terms of its visibility, at least in the United States and the community, is the 21 gene recurrence score, because it's shown promise both in being prognostic and predictive of chemotherapy response. But as I showed you today, there are other assays that are beginning to emerge, and these assays clearly appear to have benefit. For example, the BCI Endopredict and PAM50 appear to be prognostic for late relapse, and the BCI looks like it may be predictive for late relapse. And obviously, we also have the data with regard to Medicare now covering the BCI. So I think these are assays that we will begin to use in our practice, and hopefully this provides a nice overview about how we might use them. Thank you.
Thank you, Dr. Getz. At this time, I would like to introduce our next presenter for today's program, Dr. Sarika Jain.
It's a pleasure to be speaking to all of you today on behalf of NCCN as it pertains to San Antonio updates on adjuvant therapy. So the theme of this talk is to discuss how much therapy is too much or not quite enough for early-stage breast cancer as it relates to ER-positive, HER2-negative breast cancer, HER2-positive breast cancer, and finally, we'll take a look at a trial evaluating the role of additional chemotherapy for residual disease in HER2-negative breast cancer. So starting with the first topic of ER-positive, HER2-negative breast cancer, I'll first turn your attention to this Danish study. Many studies to date have shown us that chemotherapy is unnecessary in many ER-positive breast cancers. And this older Danish study explored this concept more recently. As a background, intrinsic subtypes have been proven prognostic in many settings and may predict benefit for chemotherapy. This study was a phase 3 trial in high-risk premenopausal breast cancer patients who had undergone a mastectomy, axillary lymph node dissection, and radiation. They were then randomized to adjuvant chemotherapy with either CMF, Cytoxan, or no adjuvant therapy. The hypothesis of this recent study was to look at patients with immunohistochemically defined luminal A tumors and to see if they derived any benefit from chemotherapy, with the hypothesis being that they did not derive benefit from chemotherapy. So taking a look at the initial study results of the Danish trial, we see that chemotherapy significantly improved 10-year disease-free survival and 25-year overall survival compared to those who did not receive chemotherapy. The authors determined intrinsic subtype by immunohistochemistry, and they defined luminal A subtype by the following: ER positivity, PR being greater than 20%, HER2 negativity, Ki67 13% or lower, and CK5-6 EGFR negative. The other subtypes are defined there, as you can see. So when we look at prognosis by subtype, we can clearly see that patients who are defined as being luminal A strict have a significantly better disease-free survival and overall survival compared to their luminal B and HER2 positive counterparts. Furthermore, they looked at prediction of chemotherapy benefit by subtype. When looking here on the left, patients who were considered to be non-luminal A, there was a significant benefit with chemotherapy in terms of disease-free survival. However, on the right, when looking at those who were luminal A strict, there was no significant difference between patients who received chemotherapy versus those who did not receive chemotherapy. And again, we see the same result when looking at overall survival. No change, no significant difference in overall survival in the luminal A subgroup compared to those who were considered to be non-luminal A. So in summary, this study showed us that women with luminal A breast cancers derived no benefit from chemotherapy. There were several limitations to this study, as in that it was retrospective. Immunohistochemistry has limited analytical validity to determine intrinsic subtype. There were a very small number of luminal A patients in the study. It was clearly not powered to answer this question from the outset. This was an older trial looking at generation 1 chemotherapy regimens. The patients did not receive endocrine therapy or HER2 targeted therapies. And the authors admit that materials were difficult to find, in that blocks were not saved or they were exhausted. However, this was a phase 3 randomized trial to chemotherapy versus not, with a very long follow-up, therefore showing us a very interesting conclusion. Well, who might need more therapy? I turn your attention to this Austrian study looking at adjuvant bisphosphonates, adjuvant denosumab. As a background, we know that adjuvant bisphosphonates reduce recurrence and improve survival in postmenopausal breast cancer patients. The primary analysis of this study, ABCSG 18, showed that adjuvant denosumab, given at 60 milligrams twice yearly, reduced clinical fractures by half, and that was presented at ASCO 2015. Adjuvant denosumab might have a beneficial impact on survival outcomes, was hypothesized by the authors, and the disease-free survival was reported at San Antonio this past year. To remind you, the ABCSG 18 study was a randomized placebo-controlled double-blinded study where over 3,000 patients were randomized 1-to-1 to denosumab versus placebo. And here's the disease-free survival analysis. As you can see, there is a statistically significant improvement in disease-free survival in those who received denosumab compared to placebo, with a hazard ratio of 0.82. And when they looked at subgroups, they found that certain patients or subsets of patients did do better, including those that had larger tumors, 2 centimeters or greater, those that were ductal as opposed to lobular, and those that were hormone receptor positive as opposed to negative. So in summary, the authors found that adjuvant denosumab improved disease-free survival by 18%. It was a safe treatment. There were no measurable differences in adverse events, and there were no confirmed ONJ or atypical fractures. They also pointed out that this was a similar disease-free survival benefit as seen in the EBC-TCG bisphosphonate meta-analysis. And perhaps this should be offered to all postmenopausal breast cancer patients on aromatase inhibitor therapy, irrespective of bone health. Of course, there are some limitations. We don't have very long-term follow-up, no overall survival data yet, and it could be very costly. Now going on to looking at HER2-positive breast cancer and some pertinent trials that were presented at San Antonio this past year. The first question I'd like to answer is, can we avoid anthracyclines in early-stage HER2-positive breast cancer? We look at the BC-IRG-006 trial, which now has 10 years of follow-up. To remind you, this study enrolled over 3,000 women with HER2-positive, node-positive, or high-risk node-negative disease. They were randomized to either ACT, with the T being docetaxel, ACTH, or TCH. At 10 years, you can see that clearly there is a benefit to have received Herceptin as opposed to receiving the ACT arm. But when we look at ACTH versus TCH, as seen here, there is no significant difference. 74.6% for ACTH versus 73% for TCH. Now one can question if patients who have higher risk disease would perhaps gain more benefit from anthracycline-based treatment. So they looked at just the lymph node positive patients. And again, there was no significant difference between the ACTH and the TCH arms. In fact, TCH appeared to be safer and better tolerated. In the TCH arm, there were less arthralgias, myalgias, no hand-foot syndrome, less stomatitis, and less vomiting compared to their ACTH group. There was less neuropathy, as well as nail changes and myalgias. And importantly, there were significantly less cardiac events, including less grade 3-4 CHF events and less leukemias. There was one leukemia that developed in the TCH group, but that was in a patient who had developed lymphoma and had received CHOP therapy, compared to 8 patients in the ACTH group. There were also about half the patients in the TCH group who developed an EF loss greater than 10% compared to the ACTH group. In summary, at 10-year follow-up, disease-free and overall survival showed a sustained and significant efficacy advantage of the Herceptin-containing arms over the ACT group. There was no statistical advantage of ACTH over TCH. There were more CHFs, leukemias, and a higher rate of sustained EF loss with ACTH compared to TCH. Now, we'll try to answer this question with the XNet study. Do HER2-positive breast cancer patients need more treatment? As a background, we know that following adjuvant trastuzumab, relapse occurs in up to 26% of patients at about 8 years of follow-up, with the highest risk of relapse occurring in the first 12 months following completion of trastuzumab. The XNet study looked at neratinib, which is an oral tyrosine kinase inhibitor of HER1, 2, and 4. It's been found to be effective in preclinical models as well as trastuzumab-treated metastatic breast cancer, with diarrhea being the most common adverse event seen in the trials. XNet's final study design is shown here. It did undergo several iterations and eventually included those that are HER2 positive with early-stage breast cancer who had prior adjuvant trastuzumab and chemotherapy, completed trastuzumab less than 1 year prior to study entry. They were lymph node positive or non-PAP CR after neoadjuvant therapy. They were randomized 1-to-1 to neratinib for 1 year versus placebo. The 2-year disease-free survival was a primary analysis that was presented and showed us that there was a statistically significant benefit for patients who were on the neratinib arm of about 93.9% compared to 91.6%, with an absolute benefit of 2.3%. Again, this is at 2 years. At San Antonio, they presented an exploratory 3-year disease-free survival analysis. with the N as shown here, about 3,000 patients. And we still see a sustained benefit at the 3-year mark with a hazard ratio of 0.74. The authors also looked at those tumors that were centrally confirmed to be HER2 positive, and the hazard ratio is a little bit better at 0.7, still statistically significant. But what was interesting is when they divided the patients between the hormone receptor positive and hormone receptor negative group. In those that were hormone receptor negative, there was no discernible difference between the neratinib and placebo arms. However, in those who were hormone receptor positive, there was a statistically significant improvement in disease-free survival for the neratinib arm compared to placebo, with a hazard ratio of 0.57. And when putting together the centrally confirmed HER2 positive and a hormone receptor positive group, we see here that the hazard ratio drops to 0.43. Now, diarrhea has been a major issue with neratinib, and therefore a loperamide premedication was instituted and significantly reduced the incidence of grade 3 diarrhea in these patients. So in summary, the 3-year exploratory analysis that was presented at San Antonio this past year is consistent with the 2-year primary analysis that was presented earlier, that neratinib significantly improved disease-free survival. The greatest benefit being seen in those that were centrally confirmed HER2 positive, hormone receptor positive patients as well. However, we still await ongoing data collection for 5-year disease-free survival and overall survival. There's an ongoing trial to confirm the efficacy of loperamide prophylaxis. And even though there was such a benefit seen in hormone receptor positive and HER2 positive patients that were centrally confirmed, these were subsets of subsets and very small numbers. So we await more data before we make a firm conclusion on the benefit of neratinib. Now, what about small HER2 tumors? Should we treat them or should we not? This is definitely a conundrum that we deal with in our clinics on a regular basis. As a background, trastuzumab-based therapy is effective in stage 2 to 3 breast cancer. But what about those that are small, node-negative HER2 tumors? Those patients do tend to have a worse prognosis than their HER2-negative counterparts. In fact, there's an additional 15 to 30% risk of relapse in HER2-positive T1A, T1B tumors per some retrospective series. Now, the evidence to support systemic therapy in stage 1 HER2-positive breast cancer is limited. So this was an interesting study done by the Netherlands Cancer Institute, observational study, where they looked at over 3,000 stage 1 HER2-positive breast cancer patients, looked at those that received chemotherapy with or without trastuzumab versus no treatment at all. And then looking at the chemotherapy and or trastuzumab group, they looked even further at those who received chemo plus trastuzumab, which gave us an N of about 1,400 patients. So what they did is they compared the patients who received no treatment versus those who received chemo and or trastuzumab. They admit that the baseline characteristics between the two groups were actually not balanced, in that the patients who did not receive treatment were older and had received less hormone therapy, whereas those who received treatment did have worse prognostic factors. So that's important to keep in mind as we go through the results. Here's the overall survival data that they presented at a median follow-up of 61 months, divided out by T1A, T1B, and T1C tumors. As you can see, overall, patients did very well, regardless of receiving treatment or not. But there was a statistically significant improvement with treatment if they were T1B versus T1C, or T1B and T1C. We did not see such a benefit in the T1A group. They also looked at breast cancer-specific survival, and we see in the T1C group they had a significant improvement in breast cancer-specific survival if they had received treatment versus no treatment at all. So in summary, we see that systemic therapy improved overall survival and breast cancer-specific survival in some of the stage 1 HER2-positive breast cancer patients. However, this was an observational study. There was no recurrence data that was available, so we're just going by survival data. And very important is that there were a very low number of events in the subgroups. So it's very hard to come to definitive conclusions based on this study alone. It's important to note that absolute benefit must be discussed with the individual patient based on their individual clinical pathologic factors. And finally, I'd like to conclude talking about a trial that evaluated the role of residual disease after neoadjuvant chemotherapy. Should we be giving more chemo for patients who do not achieve a path CR after neoadjuvant chemotherapy? And this is something that patients ask us, as well as something that we really would like to understand and learn more about for our patients. As a background of this CREATE-X trial, which I'll go over in more detail, patients with pathologic residual invasive disease after neoadjuvant chemotherapy have a higher risk for relapse. But it's unclear, based on current studies, if postoperative chemotherapy truly prolongs survival. The CREATE-X trial, the design is shown here. This was done in Japan, and they looked at HER2-negative patients who had received neoadjuvant chemotherapy. It could have been with anthracycline and or taxane treatment. That was not made clear in the current presentation that they gave. They then underwent surgery. If they did not achieve a path CR or node positive, they were then randomized to control, which was considered standard therapy, or standard therapy plus capecitabine. It's important to note the dose in capecitabine that they used, which was 2,500 milligrams per meter squared per day, days 1 to 14 every 3 weeks, and they received 8 cycles of this, with the primary endpoint being disease-free survival. So if we look at the disease-free survival on the left here, there is a statistically significant improvement with capecitabine, 82.8% at 5 years compared to 74% at 5 years, capecitabine versus the standard arm of no capecitabine. Furthermore, when we look at overall survival on the right, at 5 years, 94% are living compared to 89.2% who are living, 94% on the capecitabine arm, 89% on the non-capecitabine arm. All of this statistically significant, hazard ratio of 0.6. When they took a look at subgroup analyses for disease-free survival, they found that those that were hormone receptor negative, as opposed to those that were hormone receptor positive, gained the most benefit from capecitabine. And finally, in terms of adverse events, it was actually very well tolerated in this population. They saw about 7% of patients with grade 3-4 neutropenia in the capecitabine arm versus 2% in the control arm. Only 3% developed diarrhea, or I should say grade 3-4 diarrhea in the capecitabine arm versus less than 1% in the non-cape arm, and about 11% who developed grade 3 hand-foot syndrome. So in summary, CREATE-X showed us that postoperative chemotherapy after neoadjuvant chemo containing anthracycline and or taxane improved disease-free and overall survival in HER2-negative breast cancer patients with residual invasive disease, and that toxicities were quite manageable in this group. So this is very, very provocative, but is it practice changing? Well, there are several limitations to this study. First of all, it's critical to really know what the doses and the duration of their neoadjuvant chemo was. Is it similar to what we would give here in the States? So that was unclear. Furthermore, there's an unclear benefit in the hormone receptor positive tumors. If we want to adopt using capecitabine for these patients, should it be just for those that are hormone receptor negative? The doses of capecitabine were also higher than used in the United States. Perhaps the pharmacogenomics were at play in the population that was studied. And with that, I'd like to thank you.
Thank you, Dr. Jane. At this time, I would like to turn the presentation over to our final presenter for today's webinar, Dr. Santamaria.
I'm going to be discussing San Antonio updates regarding neoadjuvant therapy. So we'll discuss the pathologic complete response and survival, our experience to date, particularly regarding carboplatin triple-negative breast cancer. There were a couple of studies, the JEPAR-6 and CALGB 406-03 studies that reported their survival endpoints. We'll move on then to discuss BRCA status and response to specific therapies such as bevacizumab and platinums. We'll discuss some studies presented regarding small molecule inhibitors in HER2-positive breast cancer, particularly focusing on biomarker development and how that might help identify patients most likely to benefit from some of these specific therapies. And then finally, we'll just touch on a couple of novel approaches using drugs we use in the metastatic setting that are now being studied in the neoadjuvant setting. So pathologic complete response is a surrogate for survival for the individual patient who is able to achieve this. Multiple studies and meta-analysis have found a correlation with pathologic complete response and event-free and overall survival. And based on these data, we've hypothesized that a drug's ability to affect pathologic complete response rate may suggest that there may be a survival benefit from that given drug. So one of the drugs that have been studied in the neoadjuvant setting has been lapatinib, with numerous studies showing that the addition of lapatinib to trastuzumab improves pathologic complete response rate. Taken point for the neoadjuvant study, where the addition of lapatinib to trastuzumab had a pathologic complete response rate of 51% compared to just trastuzumab along with chemotherapy, which gave a path CR rate of 30%. Although these studies were not powered to detect survival benefit, the confirmatory ALTO study, the adjuvant study investigating lapatinib in addition to trastuzumab, found that in fact the addition of lapatinib did not improve survival endpoints, and this was presented at ASCO a couple years ago. Similarly, with bevacizumab, numerous studies in the neoadjuvant setting have consistently shown improvements in pathologic complete response rates amongst different subtypes, particularly in triple-negative breast cancer. However, the confirmatory adjuvant studies have never been able to demonstrate any benefit in terms of disease-free survival or overall survival. Therefore, neither lapatinib nor bevacizumab are considered to be a standard of care in early breast cancer. One situation where changes in path CR rates have correlated to survival endpoints has been with trastuzumab, and the neoadjuvant Herceptin study found that the addition of trastuzumab to chemotherapy improved the pathologic complete response rate significantly from 19 to 38%, but this was also associated with improvements in event-free survival and even overall survival. Certainly, numerous other adjuvant studies have confirmed that the addition of trastuzumab does improve survival, and this is considered a standard of care. And one of the few instances we see a correlation with improvement in path CR rate correlating with survival endpoints. So this brings us to carboplatin, particularly in triple-negative breast cancer, where several studies have again consistently found improvements in pathologic complete response rates. And we'll discuss in a little more detail the JEPAR-6 and CALGB-40603 studies, who presented some of their survival data at last year's San Antonio. The CALGB-40603 study was a randomized phase 2 neoadjuvant study where, using a 2x2 factorial design, investigators assessed bevacizumab and carboplatin in combination with standard chemotherapy, paclitaxel and dose-dense AC. You can see the different treatment arms there. As this has been consistent with numerous studies, we see that those who are able to achieve path CR do have improved survival compared to those who are not able to achieve path CR. You can see the 3-year event-free survival rates here are 62 and 86% respectively, favoring those who achieve pathologic complete response. However, when you look at these data by allocation to treatment arm, the addition of carboplatin was not associated with an improvement in event-free survival, where you can see here the p-value is 0.36. Similarly, overall survival was not different between the two arms. In contrast, the JEPAR-6 study was a study looking at HER2-positive and triple-negative breast cancer. This analysis focuses on the triple-negative cohort. And just to give you a sense of the different treatment arms, This study investigated carboplatin versus no carboplatin in combination with several non-standard regimens, including bevacizumab and Doxil, and as well paclitaxel, which of course is standard. You can see in the triple-negative cohort, there was an improvement in pathologic complete response from 36.9 to 53.2%. And when you look at the whole cohort, including the HER2-positive patients, there really was no difference between them in terms of disease-free survival. However, when you look at the triple-negative subset, there is a statistically significant difference in 3-year disease-free survival, where those who received carboplatin had 85.8% of disease-free survival compared to 76.1% in those who did not receive carboplatin. So just in summary, these two studies, you can see that they are using non-standard U.S. regimens, which makes their interpretation a little more tricky, and they are using different carboplatin doses as well, with the CALGB study using a Q3 week, and the JEPR-6 are using a more dose-dense weekly version of carboplatin. We don't know if there might be something to this, perhaps explaining the differences in studies. As you can see, both did improve pathologic complete response rates, but the JEPR-6 though did show a survival benefit, whereas the CALGB study did not. We do know that adding carboplatin does increase toxicity and may affect the completion of standard therapy. Given these discordant results in these relatively small phase 2 studies, this is not ready for standard use or routine use, and rather I would encourage clinical trial participation for patients considering neoadjuvant therapy in these situations. So we'll switch gears a little bit and talk about BRCA status and chemosensitivity. So we know that patients with BRCA mutations have defects in homologous recombination, and both in the metastatic and neoadjuvant setting, platinum sensitivity has been demonstrated. In the JEPR-6 study, the one we just reviewed, they found that patients who had BRCA mutations did not benefit from the addition of carboplatin, which is a little contrary to previous data reported suggesting these might be patients who benefit more from platinums, whereas it was the BRCA wild-type patients that did have a benefit and improvement in path CR rates with the addition of carboplatin. This similarly translated to a disease-free survival benefit in this subset analysis. And I think it's important to note these are relatively smaller numbers, particularly in those who are BRCA mutated. But you can clearly see here that the patients with BRCA wild type who got carboplatin did not, there was a difference in their disease-free survival. But those who with BRCA mutations all did similarly well. Switching gears a little bit, looking at BRCA status and sensitivity to other agents, particularly bevacizumab, the JEPR-Quinto study was a neoadjuvant study comparing bevacizumab versus with chemotherapy versus no bevacizumab in a neoadjuvant setting. And in the triple negative subset, there was certainly an improvement in pathologic complete response rates with the addition of bevacizumab. However, this analysis focuses on patients with BRCA mutations. And we can see that among patients with BRCA mutations, there did seem to be higher pathologic complete response rates when bevacizumab was added. You can see in mutation carriers, bevacizumab had a path CR rate of 65.7% versus 38.3% in those who did not get bevacizumab. There was a small benefit in BRCA wild type as well, however. The investigators suggest possible reasons for these findings might be that hypoxia has been described to cause DNA damage, and synthetic lethality is a described phenomenon of BRCA1/2 mutation carriers. And furthermore, angiogenic factors are overexpressed in BRCA-mutated tumors and thus may be more sensitive to these anti-VEGF therapies. So in summary, for patients with BRCA mutations considering neoadjuvant therapy, we do know they certainly respond very well to chemotherapy. I think the responsiveness to platinums is not yet clear. We do need further studies. The data we received in San Antonio last year was a little discordant with previous experiments, so more research is certainly required. Other novel therapeutics still require additional research as well, including the anti-VEGF therapies. And as with non-BRCA mutation carriers, I think consideration of clinical trial participation is important so that we can learn, and hopefully these patients can benefit from some of these therapies. Switching gears now, discussing tyrosine kinase inhibitors in HER2-positive breast cancer, we'll talk about lapatinib and neratinib. So the NSABP Foundation study presented a neoadjuvant study where patients were randomized to paclitaxel with trastuzumab followed by AC, paclitaxel with neratinib followed by AC, or the combination of paclitaxel, neratinib, and trastuzumab followed by AC. They found that, as expected, there was more diarrhea with the addition of neratinib. But overall, it was reasonably well tolerated. And in the overall cohort, there does seem to be some improvement in pathologic complete response with the addition of neratinib to trastuzumab-containing therapy. This seems to be largely driven by the hormone receptor negative cohort, where the biggest difference in path-CR was seen. There was some preliminary analysis of predictive biomarkers that were assessed. Certainly, as we saw, the estrogen receptor may be a potent predictive biomarker where ER-negative status was associated with better response. And they also found aberrations in the FCG-R3A gene may also predict response. Interestingly, PI3K, PIK3, and TILs were not predictive of response. And moving along, and the new ALTO biomarker studies were also presented. And again, just to remind us, a NEO-ALTO study looked at lapatinib in a neoadjuvant setting, lapatinib with paclitaxel, trastuzumab with paclitaxel, or the combination of both anti-HER2 agents with paclitaxel. And we know that the combination certainly does improve pathologic complete response rates. And what was interesting and consistent with previous data, that PI3K mutation showed a negative association with path-CR rates, which it makes sense given that the PI3K, PIK3 is a known resistant mechanism. Further pathway analysis find that the ROE pathway wild type and PI3K mutations, patients with those mutations did seem to have better outcomes with a combination of lapatinib and trastuzumab. And these are the sorts of studies that will hopefully help identify what subset of patients may benefit from some of these very specific therapies. And then finally, we'll touch base on some novel neoadjuvant therapies that were investigated, including TDM1 and palbociclib. TDM1 is an antibody drug conjugate linking trastuzumab to enhancing and is approved for HER2-positive metastatic breast cancer. Palbociclib is a CDK4/6 inhibitor approved in ER-positive metastatic breast cancer. So the ADAPT study investigated in HER2-positive, hormone receptor-positive breast cancers TDM1 versus TDM1 with endocrine therapy versus trastuzumab with endocrine therapy. And they really found quite remarkable activity with TDM1 with or without endocrine therapy, with path-CR rates in the 40s, 41 and 41.5 with endocrine therapy, compared to trastuzumab with endocrine therapy that only had a pathologic response rate of 15.1%. Certainly more studies are required to further investigate the role of TDM1 in early stage HER2-positive breast cancer, but certainly these data provide a lot of rationale for that. There was a neoadjuvant palbociclib also presented, where patients were with ER-positive breast cancer were started on anastrozole, and then a cycle later, 28 days later, palbociclib was added, and several biopsies were obtained during therapy to assess some specific biomarkers. This combination was certainly active, with almost a quarter of patients achieving a complete clinical response and a large portion achieving a partial response as well. One interesting finding was that when patients were started on these medications, you can see that the Ki-67 from the initial biopsy to one cycle afterwards decreased substantially with just anastrozole, and even more so with the addition of palbociclib. In patients where there was a washout period of the palbociclib, we see there was actually a rebound Ki-67 effect, versus in patients where they had their surgery within a couple of weeks of discontinuing their palbociclib, the Ki-67 remained suppressed, which it shows really the pharmacodynamics of this drug able to arrest the growth cycle. So just in summary, the indications for the neoadjuvant therapy remain the same. These are largely surgical indications, certainly inflammatory breast cancer, and certainly research. The neoadjuvant setting is a very powerful research setting because it can identify biological and clinical activity of novel drugs, but also provides tissue-based biomarkers where we can really learn about how some of these medications are working. Pathologic complete response is a surrogate for survival for the individual patients. However, improvements in path CR rates due to a drug don't necessarily lead to improvements in survival. There's now a couple of instances where it has been, but several instances where it has not correlated. The depth of the pathological complete response may matter. The drug definitely matters. Its effect on the biology certainly matters. It's important to use caution when using neoadjuvant therapy with no survival validation. These are additional toxicities you're potentially exposing patients to, and it's important to use caution when extrapolating neoadjuvant data into the adjuvant setting, again, when there's no survival validation. I'd like to acknowledge the Northwestern Breast team and the San Antonio presenters who kindly provided their slides, Dr. Sikov, von Mitschwitz, Bashing, Husai, Jacobs, Ma, Harbeck, and De Los Santos. Thank you.